I always like to start my presentations off by kind of giving you a teaser and a did you know. Did you know that starting at around the age of 35, testosterone levels in men um, between the ages of 40 and 70 decline by about 2% per year, and men considered to be in quote good health generally maintain levels 10 to 15% higher than men in poor or average health. And again, this is in men aged 40 to 70. And I always ask, well, what about younger men? Hello. But there is a clear-cut correlation here between declining testosterone levels, declining hormonal levels as men age, and the impacts that it can have on health. And we'll be talking about some of those today, and you'll see a reminder of this slide later on. When I start diving into looking at hormones, I always describe this to my patients, and feel free to please use this because I've been using it for a long time, explaining the three main hormone centers in your body. Of course, there's a whole slew of hormones, and we're going to be talking about a bunch of them today with respect to metabolism, looking at insulin and glucagon and a variety of others. But, obviously, essentially, you have your HPT axis here, your thyroid, you have your HPA axis, your adrenals, and then, of course, down here, you have your male or female hormones, depending on who you are. And I always draw these things with a double-sided arrow, meaning, each one of these hormones is impacted by the other. And especially as we age, a lot of the functionality of some of these hormone systems don't work as well as they once did. Or if there's some kind of clinical issue going on where there's a deficiency of these particular hormone systems, then usually what happens is that, oftentimes the other hormone systems have to pick up the slack, right? And so sometimes what we see in clinical practice is if one system is out of whack, a lot of times multiple systems are out of whack because unfortunately they have to also pick up the slack. And we'll be talking about this relationship way later on in the presentation, looking at the relationship specifically between the adrenals and the male hormones. And maybe talking about some strategies that can certainly help. And in the middle of this triad, I put nutrition and vitamin mineral status at the top of what the things that can potentially impact these different hormone systems. And obviously we're going to be looking at metabolism and nutrition a whole lot today. And, as I've gotten deeper into my practice over the last 14 years, I've realized that a lot of my hypogonadal men who come in to see me have some of these nutritional imbalances going on or even pre-diabetes or insulin resistance. And that's definitely been an area of focus of mine over the last five or so years, and that looking at these relationships and understanding how to be able to help them better. Of course, gastrointestinal health, looking at the state of one's gastrointestinal barrier, making sure that it's functioning well is extremely important. Inflammation, and I'm sure you guys study this as much as I do, looking at the relationships between inflammation, of course, and how that inflammation can affect the hormone systems, and then, of course, how those deficiency of these hormone systems can then impact the inflammatory pathways as well. And then a whole variety of lifestyle factors can, of course, make or break some of these hormone systems, including our exercise, how much we exercise, how much we sleep, how much we're stressed. None of us have stress, especially, post-pandemic world. I'm sure none of us have stress. Environmental factors, I put this towards the bottom of this triad, or at least the things that affect the triad. And our environment is definitely impacting us more and more these days, and we need to understand those relationships of how the environmental factors are also affecting our hormone systems. And then lastly, I put genetics on here. Genetics definitely play a role in this. Maybe not as much as we once thought they did, but they certainly are contributory factors. So no hormone discussion is complete without, of course, reviewing our basic pathophysiology and looking at these negative feedback loops, specifically related to the hypothalamic, pituitary, and testicular axis. So of course, we have at the top here, we have our hypothalamus, who signals the pituitary to release two different hormones, LH and FSH. FSH, of course, relates to the Sertoli function, helping to produce sperm, and the LH, which of course is helpful for producing testosterone from the Leydig cells. And like most negative feedback loops, once we have enough testosterone down here, it signals back to the pituitary and the hypothalamus to say, hey, we've got enough down here. You can stop sending out your hypothalamic and your pituitary hormones now. And so, of course, this is important because we look at these types of relationships between LH and FSH and testosterone when it comes to evaluating our patients and understanding how the feedback loops are functioning, and also looking at these total testosterone levels in relationship to the other hormones that are being released from the upstream systems. There is other accessory hormones here like inhibin, which is also released from the testes, which inhibit the secretion of GnRH. It's a kind of a fallback mechanism here. And then, of course, the Leydig cells who do release testosterone, the testosterone in and of itself is also important for helping to generate more sperm. So that is also another thing to remember about this. Okay, so once the testosterone has been produced, then what happens to it? And so, this is important to be able to explain, I think, to patients, especially in light of the labs that you're running on them, in terms of understanding the different pathways and how it all fits together. So we have our total testosterone pool here, and most of our testosterone is in a bound format. That's how it kind of usually works, in that 40 to 80% of our testosterone is bound strongly to sex hormone binding globulin, so SHBG. So it's very strongly bound. And this, of course, is a carrier protein that helps to transport not just testosterone, but other sex hormones throughout the bloodstream. Without these, these are kind of like our shuttle buses. So we need the SHBG, we need the albumin to help carry these hormones throughout the bloodstream and then drop off the hormones or the passengers on the bus wherever they need to be dropped off at their bus stops. Of course, the bound testosterone to albumin is a little bit weaker, so it falls off a little bit easier. But this is really important, especially when it comes to looking at our aging male patients, and that looking at SHBG levels is very important to understand what proportion of our testosterone is being bound up to this particular carrier protein. And then, of course, testosterone has the capacity to be converted into other hormones. Of course, we have our DHT here, our dihydrotestosterone, which is converted by 5-alpha reductase enzyme. And of course, DHT has been linked to things like premature hair loss and also prostate enlargement in men. And so that is an important hormone to be looking at as well. And then there's some conversion into estrogen here via the enzyme aromatase as well. So, and then lastly, the smallest percentage of everything is the free testosterone. This is the bioavailable portion of testosterone that your body can use to do all of the amazing functions and be able to affect the nucleus of the cell and cause action to happen. So the free testosterone is an important proportion of the testosterone that is released. And total testosterone, therefore, does not reflect the bioavailability of testosterone at the cellular level, because it can be converted into all these other different things. And again, we want to have adequate levels of free testosterone floating through the bloodstream. So it is important to look at this entire pathway in totality when we're evaluating our patients' labs to say, okay, this is what's going on, as opposed to maybe kind of what used to be done, which is looking at just total testosterone and a free. So it is important to look at estrogen levels, and it is important to look at DHT, and it is important to look at SHBG. And we'll be looking at a lab evaluation later on. So starting at around the age of 35, as I mentioned earlier, testosterone declines in general about 1% to 2% per year. And again, men considered to be in good health generally maintain levels 10 to 15% higher than men in poor health or average health. And what has been shown is that longitudinal studies of individual men have shown an even worse decline at about 1% more per year than what the cross-sectional studies showed. So this is an important facet in that, now we're seeing, hey, maybe the testosterone levels are actually declining by about 3% per year, or even 3 to 5% per year, depending upon the person that we're studying. So this is an important facet in that, that's a pretty big jump, especially as men get towards their late 30s and into their 40s. Testosterone oftentimes precipitously declines. So it's clear that testosterone and hormone levels decline with age. And there's also mounting evidence that the average population testosterone levels and other facets of men's health, including sperm counts and other markers of health, are also declining steadily by the decade as well. And this particular study here looked at population average testosterone levels in same age men, and they found that they dropped about 1.2% per year, or 17% cumulative from 1987 to 2004. So these are important things. Again, a lot of guys are like, I felt great when I was 25. I felt great up until I was 30. And then something just kind of over time, I just started noticing that I had less energy and less sex drive and less motivation. Part of that is because this is declining over time. It's consistent with similarly observed population declines in sperm counts and quality of sperm over time, increases in testicular cancer, hypospadias, and cryptorganism, which all comprise the testicular dysgenesis syndrome. So it is clear that our male population is now starting out older. That is very important. And more men younger than 40 now are experiencing symptoms of androgen deficiency. So this used to be, a condition of older men, and now that's just not true. I see a lot of younger guys coming into my practice who have similar issues, and we have to understand what is going on here. What is going on? And of course, it's not just one thing. And that's always the damning thing about clinical practice, but also the fun thing too, because you get to dive into the cases and try to really understand what's happening with your patients. But it's a multifactorial process. I think lifestyle factors and poor nutrition, and now what we are understanding, metabolic dysfunction, all are contributing in a big way to our hypogonadal patients. And even more importantly, our environment and environmental causes are wreaking havoc more than ever. And that really, I think, is one of the biggest things that we're seeing, unfortunately. So a lot of these chemicals that, unfortunately, that we're taking into our bodies every single day via inhalation or through our skin or from our food, a lot of them are considered hormone disruptors. And so some examples of these are phthalates that are found a lot in our plastics and plastic water bottles, our bisphenols, including bisphenol A and other bisphenols. It's found a lot in our, the lining of our cans and a lot in our plastics as well. PCBs, which of course are ubiquitous in our environment, especially in our waterways and our ocean. And so we're getting a lot of our PCBs from the fish that we're taking in, unfortunately. Glyphosate, which is, of course, Monsanto's creation, or at least part of the products that he created over the years are part of his creation. And now we're being linked to, of course, a lot of different types of hormonal disruption and also really serious forms of cancer, including lymphoma. DDE and DDT, of course, these things are not really sprayed anymore, but they're found ubiquitous in our environment and they're not going away. They're not biodegraded over time. And of course, they end up in our waterways and end up in our groundwater, and we take them in every single day. And that's just unfortunate.